So hiatal hernia is actually very common. So we see that in almost 50 to 60% of all endoscopies we do. In fact, if I had to place bets, I would say that one in two people in your even in the vicinity of the listener has a hiatal hernia. So it can cause hoarse voice as well because the acid actually gets into your vocal cord and starts irritating that. It can lead to over long run can lead to polyps on your vocal cord. Your voice can get hoarse. If you're into singing, for example, you may suddenly notice that your voice is a little bit more raspy and you're not able to sing or sing at a high pitch. Each pylori is a bacterial infection of the lining of the stomach. Okay, so that is a bug that is actually very prevalent out there in the society. In fact, some studies say that up to 50% of people might actually have it.
One advice is, be open with your physicians. Tell them everything that you are having. Keep a food log, and these food logs really help. It's an easy way to know if the particular food that's causing you discomfort.
Hey there. Before we dive in, I wanted to say thank you so much for listening. You know, we created BioBelly because gut health changed everything for me and the people I love. I watched my best friend Ankit battle ulcerative colitis and my aunt battle IBS-C, so irritable bowel syndrome with a predominance of constipation. And seeing their journey, I realized how broken the system truly was. Because there is a huge information gap between how our body works, what are the root causes of our gut health issues, and what that means in terms of the course of action to take to get on a fast track towards long term health and wellness. Because we have such a big information gap, there is this over reliance on short term fixes that really never get us to the solution we truly deserve, which is good health for the long term. And that's exactly why the BioBelly Show exists. It serves to have conversations with medical professionals from all schools of medicine, whether it's gastroenterologists to IBS dietitians to gut hypnotherapists to CBT experts, which are cognitive behavioral therapists. And the goal is to learn from them and understand what the root causes can be, and hopefully that will tell us exactly how it is we can take great strides towards our long term wellness. So, if these conversations do give you value, we would really love it if you would hit the subscribe or like the video or even comment, because it shows us that what we're doing here is really solving that problem, which is filling that information gap and hopefully providing us the information we need and the support we need to long term health and wellness. So, without further ado, let's hop into our episode. Hello, everyone. Today we are back at the BioBelly Show with a new guest, a guest that I have been waiting for very much. And I'm so lucky that we've have him today. Dr. Veeral Oza. Dr. Oza is a board certified gastroenterologist and chief of gastroenterology at Bon Secours in Greenville, South Carolina, where he leads one of the strongest interventional endoscopy programs in the state. He's also a clinical associate professor at Edward Via College of Osteopathic Medicine and has dedicated his career to advancing care for GERD, gallbladder issues, and pancreatic diseases while mentoring the next generation of GI specialists. Today, we're diving into how he approaches some of the most common and often misunderstood gut issues. Dr. Rosa, thank you so much for being here today.
Thank you for having me. That was a mouthful there.
Yeah. It's funny sometimes gastroenterologist guests that we have, sometimes I do background research on publications they did. And I can't tell you some of the words of those titles. They are such tongue twisters because, there's so many
Yeah.
medical terms. So half of it is just me searching up how to pronounce these words. So,
Yeah, no, that's true. So that is very true.
yeah. So, Dr. Rosa, if you can take me back to your beginning, what drew you specifically to gastroenterology and, learning about and also specializing in things like treating GERD, and which is gastroesophageal reflux disease for those who don't know, and also just these gallbladder and pancreatic diseases that we see time and time again.
Yeah, so when I was doing my residency in internal medicine at George Washington in DC, we had a fairly good, strong GI program, but it was an inner city hospital, so we saw a lot of, an academic hospital, so we saw a lot of pathology across the breadth of internal medicine, cardiology to pulmonology to GI to kidneys to you name it, we saw it. And one of the things that drew me to GI was the ability that no two patients were the same. We'd have a patient with the same symptoms. For example, you mentioned some things earlier, who have bloating and say nausea. Well, bloating and nausea could be from reflux. It could be from IBS. It could be from IBD, which is Crohn's and ulcerative colitis. It could be from gallbladder problems. It could also be from pancreatic problems. It could be from a number of different things. And it's the same symptom, bloating and nausea. So to me, I was drawn by the Sherlock Holmes approach of doing the necessary testing, whether it's endoscopy or labs or scans, to try to deduce. And it was more deductive reasoning rather than just kind of putting patients in different silos of, oh, you've got this problem, you've got this type of issue, got this problem, got that type of issue. And I didn't really like that approach, and my brain is more designed to do deductive reasoning. And then of course there's the added benefit of doing endoscopy, where you're basically playing a little computer game every day, more or less. And when you're doing sculpture, it almost feels like you're playing a computer game, because you've got a screen in front of you, you've got your scope, which is kind of like your joystick. So it's kind of cool and very rewarding that you're blessed to be in a position where you're able to take care of these patients endoscopically, diagnose them, in many cases fix them. If you have, say, for example, a stricture or a narrowing, say, in the food pipe or stomach or small intestine from various conditions, ulcers, old ulcers, cancers, you're able to put a stent across it, and suddenly that area opens up. People are able to start eating again, for something as simple as that. So that's kind of what I do in interventional endoscopy. Stretching out some benign strictures in the food pipe to make sure people can start eating again. So those things are very rewarding to me personally. So it was great that you not only had deductive reasoning happening almost on a daily basis in clinic and in the wards, but also you're able to do endoscopy and fix some of these problems and diagnose patients and give them closure. So I found it very rewarding, and that's kind of what drew me to GI. And thankfully, I was not wrong.
Awesome, awesome. Yeah, I have to ask so many questions, like especially the upper endoscopy. It is something I am starting to learn, but specifically this issue of gastroesophageal reflux disease. It's so funny, Dr. Rosa. A lot of us trying to figure out the landscape of gut issues, specifically in America, that people are suffering with. I really just look at these public forums like Reddit, where I'm trying to see, because there's like these groups of people with these gut issues, and specifically GERD. Literally, like, I have notifications popping up every single hour on, okay, like another post on, I can't deal with my GERD, I can't deal with this acid reflux, or people like complaining about them not being able to sleep without feeling that acid reflux, so they have to like get a pillow and sleep on their left side. And I was wondering if you can teach us a little bit about what exactly GERD is and how it's actually different from occasional reflux.
Yeah, so GERD is acid reflux, gastroesophageal reflux disease that's related to strictly acid. The stomach is making more acid, or making the normal level of acid, which somehow gets into your food pipe, and that's what you're really feeling. You're feeling that because your esophagus, your food pipe is not designed to see any acid. So when it sees that, it tends to spasm. It can kind of move in a more rapid manner. You can have that taste in your mouth, can lead to more bloating like sensation, can also cause more belching. Just being very uncomfortable. It can feel like you're having a spasm in your chest, or chest pain sometimes as well. So it can cause hoarse voice as well, because the acid actually gets into your vocal cords and starts irritating that. It can lead to, over long run, can lead to polyps on your vocal cord. So your voice can get hoarse. If you're into singing, for example, you may suddenly notice that your voice is a little bit more raspy, and you're not able to sing or sing at a high pitch. So some of these things do have real, it's a very simple problem, reflux, but can have some very real long-term sequelae for patients. It can really result in some life-altering things like you mentioned. So that's acid reflux. Can we fix it? Of course we can fix it. There's medications to fix it, which is normally first line. There's endoscopy ways to fix it. If you have a mechanical issue such as we call a hiatal hernia, or a portion of your stomach is sliding back and forth between your chest and your foot and your belly, then that's something that a surgeon can fix it. There's ways to endoscopically go down there and do something called a TIF, which is creating a little partial wrap of the food pipe and the stomach food pipe junction, and that's done endoscopically. There's also surgical techniques to make that area a little bit more. But then there's also the component of a non-acid reflux, which is actually there's ways we can actually
Understood.
test the acid levels in your food pipe, and people can feel symptoms of reflux, and that's related more to spasm and actual movement of the food pipe, and that's not necessarily associated with true acid. So if you have something called non-acid reflux, then your physician may put you on specific medications that are not geared towards reducing acid amount, but they're geared more towards improving motility of the food pipe, meaning the movement of the food pipe, making it more coordinated, or sometimes which can help with relaxing some of the muscles in the food pipe or stomach. So it just depends on what patient has before you proceed with the therapeutic option.
Understood. Understood. I really appreciate you mentioning things like hiatal hernia, and because that's specifically one of the questions I was about to ask, because it just happens so commonly. Like, people are sharing about these issues. So I was wondering, like, what are the most common causes you see for these different factors like hiatal hernia, and how does H. pylori infection actually fit into the picture?
So, H. pylori is a bacterial infection of the lining of the stomach. Okay, so that is a bug that is actually very, very prevalent out there in the society.
Hmm.
In fact, some studies say that up to 50% of people might actually have it. 50%, but it doesn't cause a problem in everybody.
Yeah.
It causes a problem in a very small subset of patients.
Mm.
H. pylori results in chronic inflammation of the stomach lining, which can then actually lead to ulcers forming in the stomach. It can even lead to ulcers forming in the small intestine. So H. pylori is a bacteria that does need to be treated, because over the long run, if you don't treat that, if you don't treat these ulcers, H. pylori related ulcerations can lead to gastric cancer or cancer of the stomach. So the treatment's actually very simple. If you detect H. pylori, you put people on antibiotics, and it fixes the problem in the majority of cases.
Understood. Understood. And earlier you were talking about how we test this acid in the food pipe to be able to see if that acid reflux is acid, like if it's not just occasional reflux, but it is actually acid reflux. What are those
Mhm.
tests that we are looking at that are giving this information to the medical providers?
Yeah, so it's like a little probe that actually goes into your food pipe. It's called a pH probe. Endoscopists can actually plant that through the mouth, and when they're doing endoscopy, they just put this probe direct into your food pipe, and it just sits there, and you have a little recorder the size of it's actually sitting right here. Surprisingly, it's in my office here. So this is the actual cover for the recorder, but this is basically the size of the recorder. It just sits there and is recording the acid levels. And every time you feel like you're having a heartburn, you click a little button, and it records that as and it specifically notes that on the backside when we're actually interpreting the results, it tells us patient clicked a button here, here, and here, and we're able to see what the acid level was at that very moment, and to see if there's any correlation between symptoms and the acid level. So there's ways to record it. There's those techniques. There's also a probe that goes from your nose into your food pipe, and that's recording acid levels for 24 hours at a stretch. Does the same thing the other one does. So there's those ways to measure acid levels.
Gotcha, gotcha. And right after that, just another follow-up. You were mentioning that if it is actually not acid reflux, but it's just normal reflux, doctors will help relax the muscles in the food pipes. What is like the protocol given to relax those muscles to increase the motility of the food?
Yeah, there's a few medications that
Oh,
we actually prescribe that it's in a whole class by itself that we can actually prescribe to help with movement issues. Actually, one of the medications is sometimes even used for blood pressure. So there's medications for that that also impact the movement of the food pipe, relaxing the muscles of the food pipe. So the doses are of course different, but there's a whole class of medications for that.
got you, got you. And earlier you were talking about hiatal hernia and how surgeons
Mhm.
are usually coming onto the team if that is the case. I was wondering if you can explain a little bit more about what a hiatal hernia is and what is your approach when you diagnose it?
So hiatal hernia is actually very, 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 very common. So we see that in almost 50 to 60% of all endoscopies we do. In fact, if I had to place bets, I would say that 1 in 2 people in your immediate vicinity, even in the vicinity of the listener, has a hiatal hernia. Quite
Wow.
frankly, I might have a hiatal hernia. It's that common, but it doesn't cause issues in everybody. Hiatal hernias, they can they can get bigger over time, especially as you get older. If you're obese, things like that, there's certain components that can actually make this hiatal hernia bigger with time. Age is one factor in that, but hiatal hernia by itself, if it's a small one, it rarely causes problems. It doesn't cause issues. As it gets bigger, it can start causing more issues, and where everybody just starts having issues, that the threshold varies from person to person. Somebody might have a 2 centimeter hiatal hernia, somebody might have 2.5, somebody might have 1 centimeter, and each person might be feeling the same symptoms. So it's not a one size fits all literally. So it's actually one size may not fit all. Meaning, if you have a different size of hiatal hernia, you may or may not be having symptoms. It just depends on the individual person.
And most people actually don't realize if they have reflux until it causes damage. How do you explain? I think earlier we were talking about just occasional reflux, but I think there's also something called silent reflux, like the laryngopharyngeal reflux or LPR to patients. If you can explain that as well.
Yeah, laryngopharyngeal reflux is an interesting diagnosis. It's usually made by ENT doctors when they do a vocal cord exam. They see a lot of polyps on the vocal cords, or they see certain changes like inflammation on the vocal cords that leads them to make the diagnosis of LPR, laryngopharyngeal reflux. That's what the diagnosis usually comes from. But acid reflux by itself, some people do have silent reflux where they have no symptoms whatsoever. That being said, if you start having symptoms, I do think it's worthwhile getting checked out. Typically, physicians, your primary care doctors, your gastroenterologist will ask you to be on an acid blocker for about 7 to 10 days, sometimes even 2 weeks, and see if there's resolution of symptoms. If the symptoms return after you stop the medications, the next step is typically doing an endoscopy and taking a look in the food pipe to see how bad that area looks.
Hmm.
If that area looks like it's gotten worse, meaning the GE junction, is it a big hiatal hernia there? Is there a tumor there? A
Hmm.
number of different things that can explain a persistent acid reflux. So that is a key for your listeners, that if you have persistent acid reflux that's not improving to medications, or you stop the medication, the reflux comes back, and that is an indication to actually get an endoscopy and get it checked out.
Makes sense to me. Yeah, makes perfect sense. And specifically for this hiatal hernia and this LPR, let's start with hiatal hernia first. I'm backtracking here. Along with the surgical intervention, if it's needed, if it is as big, if it's like 8 centimeter hernia, right? Besides surgery, what are other things we can do? Because if like 1 in 2 people actually do have hiatal hernia, what are like the
Mhm.
best? Would you say lifestyle or food choices that we can be taking? Like as best practices to make sure that those like reflux like symptoms aren't exacerbating.
Yeah, so if you have a large hiatal hernia, I think I usually do recommend patients get the surgery to get it fixed. If it's a small hiatal hernia, then I think we can do all these dietary changes and lifestyle modifications, particularly things like avoiding dark chocolate, avoiding alcohol, avoiding tomato-based products, for example, avoiding oily foods. All these things can be done. Eating food that are rich in fruits and vegetables, but citrusy fruits can actually cause more reflux. So that's something to be aware of. Oatmeal can sometimes help with reflux symptoms as well. So there's some natural things that can be done if you have a small to medium sized hiatal hernia. If you have a large hiatal hernia, which 8 centimeters will qualify as, then at that point I'm just like, you just need to get surgery. We can do all this lifestyle stuff, which you should anyway, because it's going to help you with other things like managing cholesterol, diabetes, etc. But that's not going to fix your reflux. You just need to go and get surgery at that point.
Understood, understood. And speaking of solutions for gut for reflux issues, I was wondering what your view is on the role of PPIs when you feel they're absolutely necessary and when milder approaches like H2 blockers or antacids might be appropriate.
Yeah, it just depends on your symptoms, and that's what it comes down to. If you have symptoms that are, not debilitating on a daily basis, or you're just having symptoms maybe once or twice a day or once or twice a week, then I think H2 blockers, such as, some Pepsid, for example, like you mentioned, those things can work. I think it's helpful to be on those. If you have symptoms every day, all the time after every meal. You can't lie down flat because you lie down, you feel like acid's coming up your chest. That's not the time to do H2 blockers, and that's when you really want to be on a stronger medication like PPI, which is proton pump inhibitors, such as Nexium or Prilosec, for people, or Protonics for people who are interested in the name brands, and that's what the name brands are. But that is something that can be used in those cases.
Understood. And I was wondering, right? Because it's interesting in terms of gut issues. I feel like there's like a spectrum of like these schools of medicine. And on one side we have the conventional science, and then on the other side there is more of this holistic root cause approach, health and wellness. Like when you see your naturopathy, your homeopathy, your acupuncture, there's like a spectrum, and there's clinical research backing the all different approaches, and so they're all viable and very important in their own way. But I was wondering, do you think there is room for a more root cause approach to GERD? We were talking about it before, but like the diet, the lifestyle, the even just like microbiome balance, or is it usually just structural, like surgical intervention, etc.?
I mean, there's good data actually that suggests that the microbiome does play a role in someone's symptoms of reflux.
Hmm.
I think that data is still evolving, and we don't quite have all the information yet. I certainly see a future where people will be able to know based on their microbiome, what they'll have a own, almost like a genetic test, like a panel,
Yeah.
that they'll just know that, "Oh, this is what you are from a microbiome perspective, and whenever you have symptoms, you're able to test that, and they're like, oh, you're lacking in this, this, and this, and just replenish this, and maybe you'll start feeling better from a gut side as well. So I do see a future like that, not too far in the distant future. I'd say within the next 10, 15 years. I would imagine that, especially the advent of AI, I think will expedite a lot of these discoveries. In overdrive here. So I do think there'll be a different future in about 2 decades from now.
I love it.
But
I
right
love it.
now, I think right now it's just focused mostly on medications, dietary changes, doing some surgeries and endoscopies and things like that. But all this AI and microbiome is going to put me out of a job.
No, no, no. I mean, I am very hopeful, and I really hope I'll share about it more towards the end of our conversation. But I'm very hopeful that having a streamlined way to introduce people suffering with gut issues to a kind of like a dream team of sorts of gut related medical providers. I think that's one of the greatest ways to close that information gap and have it so that we will be able to give the care that people with gut issues truly deserve, whether it's IBS, right? Whether it's SIBO or even a bacterial overgrowth, like a small intestinal
Mhm.
bacterial overgrowth, fungal overgrowth. There's even like this reflux now. So occasional reflux, GERD, then H. pylori. There's like such like a vast amount of issues, but from what I'm learning, sometimes it's the same stressors, the same poor lifestyle choices we're making that are manifesting as these different issues. So super exciting stuff. And yeah, I definitely believe that AI is gonna, be able to take a lot out of our plate in terms of diagnosing people. But I do believe the personalization touch of people to people, I don't think that's gonna go away anytime soon. So you're not out of business at all, Dr. Oza. So, but moving on, I know one of your other specializations is related to gallbladder and pancreas care. I was wondering specifically the gallbladder. What are the most common gallbladder issues you see, and what typically drives them?
Yeah, the most common thing that I see in my practice, and again, this is a biased view because of this type of stuff I do, is stones. I see a lot of people who have gallstones developing that can lead to problems such as blockage of the gallbladder, which leads to cholecystitis. I have to send those patients to a surgeon. I see a lot of patients where stones tumble down. In fact, I can show you my chart here. There's a little picture I'm pointing up here. You can see the
Hmm.
little stones there.
Yeah.
I bring it up close. So there's the stones there. You can see the stones that if they block this little tube here, then you can get the gallbladder kind of get swollen. If they tumble down this main bile duct, the green bile duct here, then they can block the pipes that drain the liver, if you will. And that's typically what I do, where I go in for the scope from the mouth to the food pipe, stomach, then small intestine. I get inside and I pull all these stones out and relieve those blockages. Now that's typically what my role is, and it's a very biased role in terms of mostly because of my practice and what I do and what it entails. But a common general gastroenterologist, number one problem that we see is the gallbladder's pumping ability. It's most efficient, so it's not pumping effectively, and patients still have the same symptoms. Nausea, bloating, feeling discomfort after they eat, and those patients all almost always need a surgery to get the gallbladder out. There are some medications out there that potentially help, but in my experience, typically they'll all end up with surgery at some point. So.
Wow, wow. And why is it that these stones are being developed?
So stones can happen for a number of different reasons. Most of these stones are cholesterol stones. That if you have high cholesterol, and we're talking about really high cholesterol, certainly some of the cholesterol can precipitate out in the bile.
Wow.
But even a person with normal cholesterol can develop gallstones, and that has to do more with the actual concentration of bile, which in each person might be slightly different, and that's based on some of it's based on genetics, some of it's based on actually how fast the bile is flowing through the bile duct, the plumbing system, like how fast is the flow. Some of those things are not in our control. How fast the bile is being made, again, that's not in our control. It's just something the body naturally does. So it depends on the concentration of the bile and on some of these components of bile in the gallbladder. So if there's a lot of cholesterol there and the gallbladder is not pumping effectively, then some of these cholesterols can precipitate out of the bile and form stones.
So in the event there is a stone, usually the course of action is removing the gallbladder altogether.
If you're having symptoms,
Okay.
yeah, if you're having symptoms, most patients with gallbladder stones or gallstones will not have symptoms. Majority. I'm talking 90% of people who have stones in the gallbladder don't even know they have stones.
Okay.
So those are not people who need surgery. People who are having issues are the ones that actually need the surgery.
Got it. Got it. And in the case it is removed, speaking of like the function of the gallbladder, right? If the gallbladder itself is removed, I know that the liver produces the bile, what you were referring to, and that the bile is actually stored in the gallbladder. Please correct me if I'm wrong. And then the bile from the gallbladder is then going like in that image there. It's going into the duodenum, like near the beginning of the
Mhm,
small
mhm.
intestine. So
Yep,
it's
yep.
super interesting how the body works. But in the event there is no gallbladder, how is it like? Would the liver be able to do that work of reaching that
Yeah,
bile into the small intestine?
bile is always being made. So instead of it being stored in the gallbladder, bile will now naturally start coming out into the small intestine. So there's no, in fact, typically people have gallbladders removed. We'll actually do, if you get a scan for any reason, we'll notice that their bile ducts are a little bit bigger in size, just because now the bile acts kind of like a temporary storage area for some of this bile,
Oh,
in many ways. So it just gets dilated over time. But the liver is always making bile, whether you have a gallbladder or not. It's always doing it. The issue is if you have a gallbladder, it'll store in there. If it don't, then it's going to pour right into the small intestine majority of the times.
it's so amazing how Mother Nature does it that we can just kind of like adapt to different changes. Like no gallbladder, no
Hmm.
problem. We'll make it anyway, and we'll store it anyway.
Yeah,
Speaking of
yeah, exactly.
yeah, I know. And also pancreatic issues. With pancreatic diseases being so complex, and us knowing, the pancreas is kind of the powerhouse of making all these sorts of digestive enzymes. What are the most common issues you treat in within the pancreatic issues?
So one of the most common things that I treat from a pancreas perspective is, acute and chronic pancreatitis. That's something that I treat very commonly, and
Okay.
that's again because of my line of work and what I'm doing in the hospital. We see a lot of people with scarring of the pancreas. We see a lot of people who have stones in the pancreas duct, for instance, that sometimes need to come out. We see a lot of people who have large collections or cysts in the pancreas that develop that need to be drained, some type of cysts that actually turn into cancer, so you have to keep an eye on them. It's a very common. I want to tell you viewers that just because you have a pancreatic cyst does not mean that's what's causing nausea. Most of the times, I'm talking like over 90% of the times, these cysts are found by chance. It's not something you don't have like bloating and nausea and be like, yes, I've got a pancreatic cyst. No, it doesn't work that way. Normally you'll get a scan for something like bloating or nausea. They'll see an incidental pancreatic cyst and they'll see, say, gallstones. And people will start worrying about the cyst is causing their symptoms. I typically have to tell them, no, your problem is probably from the gallbladder, statistically speaking. A small cyst in the pancreas is not the cause of your issues. And that's almost always true, like almost 100% of the time. Now, the cyst is big and is really large and starting to push against different structures like stomach, small intestine.
then yeah, then the cyst might be the cause of your symptoms. So it is certainly worthwhile to go do something called an endoscopic ultrasound, which is what I do, and go in there and find these cysts in the pancreas, look at this area, stick a needle into it, do an analysis, see is it a benign cyst or is it a malignant cyst or is it a cyst with a it's pre-malignant, so it has malignant potential but is not cancer yet, and do we need to keep an eye on it? So those are types of things that I do. So in my world, the most common thing that I see is pancreas issues related to pancreatitis and then pancreatic cysts. Now, sometimes patients can also develop something called exocrine, pancreatic insufficiency. Pancreas, as a reminder to your listeners and viewers, is what we call the dual organ. It is an endocrine organ, which means it releases enzymes, enzymes and hormones directly in the blood, but it's also an exocrine organ as well, where it secretes enzymes directly into the small intestine. So when it releases enzymes into the small intestine, it helps digest food in the small intestine, which leads to absorption of fats and carbohydrates and proteins, so on and so forth. A lot of bulk of the work is done for absorption is done by the pancreas. So sometimes patients can develop something called EPI or exocrine pancreatic insufficiency, where they don't have the right amount or right concentration of pancreatic enzymes in the juice that's being secreted. So there's tests for that, and we can do stool tests to figure out does somebody actually have exocrine pancreatic insufficiency or not. And if they do, we can start them on pancreatic enzyme supplements, which are not absorbed in the blood but work only in the gut and help break down some of these products. So I tell patients all the time, you can't overdose on some of these pancreatic enzymes because they don't really get absorbed in the blood. So there's no way to kind of overdose on them.
Wow. Yeah, that's interesting. And what are these like supplements that we are introducing in this issue of pancreatitis, for example?
Supplements for pancreatic enzymes?
Yes. Like that, or are they just
So
the
those
digestive enzymes or?
Yeah, the digestive enzymes. They're the two companies that make two different formulations. One is called Zenpep. It's out available commercially in the market, and the other one's called Creon, also made by another company. But there's only two main formulations, and there's other ones you can get over the counter from some of the vitamin and protein mixture GNC type of stores that sell like these enzyme supplements, which again, there's no control on the FDA and where those come from. So I always tell people that you can use them, sure. I mean, they're available, you can buy them, but just be careful what you're buying because they're not approved or regulated by the FDA.
Got it. And in your experience, for this kind of umbrella of issues, whether it's pancreatitis, the exocrine, pancreatic deficiency, and even just the cysts in the pancreas that are found, are there root causes or lifestyle factors that people underestimate in the pancreatic health that might be leading to these issues?
Oh, for sure. The people who smoke, I tell them
Oh,
all the time, smoking is an independent risk factor for pancreatic cysts, pancreatic cancers, and kind of feeling not as healthy as you would otherwise anyway. Just from smoking itself is just bad. But we're also alcohol drinking. Drinking alcohol even is what leads to pancreatitis, which can then lead to a lot of other issues. But if you drink heavily, if you have family history of pancreatic cancer, pancreatic problems, you really probably shouldn't drink. Probably shouldn't smoke. Being obese, being overweight has been associated with pancreatitis and having issues with pancreatic enzyme being secreted, pancreatic enzymes being made in the body. The amount of insulin your body makes, again, insulin is made by the pancreas. So, having obesity affects all those things. So it's something to be aware of. And having a diet that's rich in fruits and vegetables has been shown to be healthy and protective for a number of different cancers, number of different conditions. Pancreas problems are no exceptions to that.
so switching gears, Dr. Rosa, I wanted to kind of learn a little bit about, or just get a sneak peek into what goes on in your mind when you're consulting a patient. Meaning, like, what are the frameworks you're using to be able to properly diagnose the issues a person might be having based on what information they're giving you after like the first preliminary line of questioning. When a patient comes in with that, like, with just vague gut symptoms, what's your framework for diagnosis? Like, how do you decide which test to run, which path to follow?
Yeah, so if they've had no workup done at all, they just have say abdominal pain. Now the first question is, finding out what type of pain it is, where is the pain, what makes the pain better or worse, is it dull, is it cramping, is it sharp, how often the pain happens, is it just after you eat? Or does the pain make it go away after you eat? Does it make it worse after you eat? So what are the aggravating and alleviating factors for the pain? So that can lead to a lot of different more questions, such as, is it associated with nausea? Do you actually throw up? Does throwing up actually help with your pain? Do you have any underlying diarrhea or constipation that might help with the pain? Have you lost weight? Do you smoke? Do you not smoke? So all those things can kind of pinpoint you in the right direction. And hey, this pain might be from maybe gallbladder, maybe colon problem, maybe it's nothing, maybe it's just an IBS type of issue, maybe it's anxiety. Maybe this pain comes in cycles. For a female patient, is the pain associated with their monthly menstruation? Are the menstrual periods regular? They could have some underlying endometriosis, for example, of the colon, which is why they also have some bleeding. So there's a number of different questions that go into play, and the line of questions you have to ask a patient to kind of try to get to the bottom of, is this upper or is this lower? Is it something I need to worry about and send the patient to the ER like now? Or do I have the luxury to wait on it? Do they have fevers associated with this pain? Those types of questions is what I would ask. Are they bleeding, like I said? Are they black stool? Are they throwing up blood? So again, all those things can kind of tell me, hey, this person needs an endoscopy or not. This person might need an ultrasound. Have they had an ultrasound already? If not, and if the ultrasound was normal, then maybe they need something more. Maybe they need a CT scan or even an MRI, perhaps. Or maybe they need me to do something more complicated, like an endoscopic ultrasound to go assess the pancreas, or assess the bile duct, or assess the gallbladder. So those types of questions is what I would ask to kind of pinpoint me in one direction versus another.
Wow, wow. So it's basically like I guess like if it is an extreme situation, you might have like a standard like just procedure of certain tests you're doing, right? Just to exclude any extreme cases. So if it is, for example, a patient comes in and they say, Dr. Rosa, I'm feeling a lot of reflux and I can't sleep at night without feeling just like a taste of pineapple in my mouth. In those cases, what are the tests that specifically we're thinking about to like rule out any like major issues?
Yeah, I mean, if it's just taste-related issues, then I think it becomes more specific and it's more niche.
Mm,
With COVID, we noticed a lot of people were starting to have loss of taste and loss of
yeah,
smell. So again, we have to think about certain viruses and certain more broadly, it's an autoimmune condition, and we kind of start going in that direction. Taste is typically not directly associated with a GI problem. It could be, it's related, of course, but it's typically not just a taste issue and a GI problem. It's just something else going on too.
got it. I just had a quick more questions for you, and it's a bit about what we were talking about before. The supplements that you were mentioning, just the idea of supplements that if they're not FDA approved, there is no regulation, and it might not be something that people trust. I was wondering, what do you think, or what do you look for when evaluating whether a supplement is credible, given that they aren't usually regulated?
So as a physician, I don't make any comments on
Okay.
non-regulated supplements. I just don't do that as a matter of practice, because patients respect and regard physician views in a very high regard. So I don't want to mislead my patients, somehow say I'm endorsing a particular supplement or another, when the reality is that I'm not even legally supposed to do that or prescribe any non-FDA related supplements. So I normally reserve any comments and don't make any comments on non-FDA approved medications or supplements. Certainly they're out there. The data is out there on some of these things. They can cause damage to the liver, for example, in some cases. So I always tell people, just be careful what you're using and be aware of what you're using. And don't just believe everything that the store tells you or the bottle tells you.
Got it. Got it. And it's funny because we are intending to make a supplement line, so we really hope it's one that is rooted in science and one that gastroenterologists like yourself could trust. Wrapping up though, Dr. Oza, final question: if you could give one piece of advice to someone living with chronic reflux, gallbladder pain, or pancreas issues, what would it be?
Yeah, well, I think the one advice is, be open with your physicians.
Yeah.
Tell them everything that you are having. Keep a food log, and these food logs really help.
Yeah.
It's an easy way to know if it's a particular food that's causing you discomfort. And food logs are underrated and not heavily used out there in the world. And I think there's a lot of room to improve that. But be open with your doctors. Tell them all the issues you might be facing and when they happen, even though it might sound embarrassing or silly. If you say it might be something gassy, like I'm very gassy and my gas smells. Tell your physician that it means something. It's something the patient. I ask my patients of their stool color all the time, and some of them look at me like I'm crazy. I'm like, no, it matters.
Yeah.
What color your poop is important. It tells me something. So share those types of information with your physician. I think it's very important.
Got it. Got it. Thank you so much, Dr. Rosa, for all your time. I believe this conversation was liquid gold for anyone with any pancreatic, gallbladder, or even GERD, like esophageal related issues. And I think the number one thing we learned is gastroenterologists aren't just care providers, but they're kind of like modern day detectives that are fully
Yes.
capable of, like, with an arsenal of tools, they're capable of making our issues of our pain reduce significantly. And
Yeah.
it's a matter of just being transparent with them so they can do their job best.
Yeah. Thank you so much for having me. It's been a pleasure.
Thank you so much for all your time, sir.
Okay.
Thank you.